Let's talk about something that is very, very common. Let's talk about gastritis and peptic ulcer disease. P.S. When you talk about gases, all you mean is abdominal discomfort, also referred to as dyspepsia. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to look at two important topics, gastritis and peptic ulcer disease. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Tell a friend to tell a friend we are doing videos on the channel. Let's go. Here's a warm-up question, which is a single best answer. A 54-year-old man complains of burning epigastric pain that improves after a meal and is occasionally relieved with antacids. On examination, he appears well, and besides some epigastric tenderness on palpation, the rest of the examination is normal. Upper endoscopy confirms a duodenal ulcer. Which of the following statements concerning peptic ulcer disease is correct? A. Duodenal ulcer is seen more often in older people than is gastric ulcers. B. Clinically, gastric ulcers are more common than duodenal ulcers. C. Duodenal ulcers can frequently be malignant. D. Infection can cause both types of peptic ulcers. E. Peptic gastric ulcers are usually quite proximal in the stomach. Write down your answer, scream it at the screen. I will give you the answer at the end of the lecture. So let's talk a little bit about the stomach and the duodenum. So remember that the stomach is going to be this muscular pouch that's going to be essential for the storage of food temporarily and also the initiation of digestion of proteins. The stomach is going to be connected to the esophagus at the cardia. There is a sphincter there that's known as the lower esophageal sphincter or the cardiac sphincter. And then it's connected to the duodenum at the pylorus, where you have the pyloric sphincter. Remember that it's going to be consisting of the cardia, the upper region, which is known as the fundus. This is the fundus, the body, and of course the antrum, which is going to be extending towards the pylorus. So remember that the cardia is going to be consisting of special types of cells, which are known as mucus secreting foveolar cells, which are these shallow glands which produce mucus that lines the stomach and protects the stomach from damage. The fundus is going to be pretty much consisting of two types of cells, the parietal cells and the chief cells. Remember that the parietal cells are the ones that are going to be responsible for the production of intrinsic factor. They're going to be responsible for the production of hydrochloric acid. Intrinsic factor is needed for the absorption of vitamin B12. I want you to keep that in mind. Then you have the chief cells, which produce pepsinogen. This pepsinogen is eventually going to be activated into pepsin for the digestion of proteins. Then the body is also going to be containing the parietal cells and the chief cells. The antrum is going to contain the G cells, which is going to be producing gastrin that's going to be secreted into the circulation to stimulate acid production. Then you also have the D cells, which are going to be producing somatostatin, which pretty much inhibits the production of acid. It also stimulates the production of mucus and bicarbonate. So remember that the pylorus is going to be separated from or rather has a sphincter which separates the stomach from the duodenum. So remember that the capacity of the stomach is roughly about 1,500 to 3,000 mils, and it's going to be essential such that the stomach is going to be innervated by a nerve which is known as the vagus nerve. And remember that the adaptations of the GIT, you have certain adaptations in certain areas, especially to the layers in the GIT that may actually serve different functions. For example, in the stomach, you have three layers of muscles. You have an innermost oblique layer, an inner circular layer, and an outer longitudinal layer, as opposed to having an inner circular layer and an outer longitudinal layer. You also have two sphincters, the gastroesophageal sphincter, which is at the lower end of the esophagus, and the pyloric sphincter, which is joining the stomach, or between the stomach and the duodenum. So remember that the pyloric sphincter is going to be largely made up of thickenings of circular muscles, and it controls the exit of gastric contents into the duodenum. And the duodenum is going to be the outer longitudinal and inner smooth muscle layers. It only has two, and it's C-shaped. So within the curvature, you have the pancreas, the head of the pancreas seated there. And remember that it's going to be terminating at the duodenojejunal flexure, where it joins the duodenum. Okay, so remember that the stomach is going to be lined by a mucosa, and this mucosa can stretch out, especially when you're feeding, and increase the size of the stomach. And the greater curvature of the stomach is actually when it is undistended. The mucosa folds and forms these ridges, which you call as rugae. Remember that the upper 2/3 of the stomach is going to consist of parietal cells, like I told you, that produce hydrochloric acid, which creates a conducive environment for the digestion of proteins. It also helps having an immunological function to kill any microorganisms that you swallow, as well as intrinsic factor, which is needed for the absorption of vitamin B12. Then you have the chief cells, which produce pepsinogen, which obviously initiates proteolysis. Remember that there is a color change at the junction between the body and the antrum of the stomach, and you can actually see this macroscopically, and it can actually even be confirmed by measuring the pH over the surface. Okay, so the antrum is also going to be containing of G cells. Like I say, they're going to be secreting gastrin, which is released into the bloodstream to produce or stimulate the production of acid. So there are two main forms of gastrin. You have G17 and you have G34, depending on the number of amino acids that are present in this. But G17 is the major form of gastric, or rather gastrin. Then the D cells are going to be producing somatostatin, which suppresses the acid production. The mucus secreting cells are going to be producing mucus and bicarbonate, which are going to be pretty much protecting the stomach, because remember that the stomach has acid in it, and it can actually digest itself. So this mucus and bicarbonate is meant to protect the stomach. Remember most of these things, because when things go wrong, this is what can lead to ulceration. Then the walls of the stomach is going to be containing enterochromaffin cells, which are going to be producing histamine, and this promotes acid secretion. So remember that the mucosal barrier is made up of the plasma membrane of the mucosa cells, the mucus layer that actually protects the gastric epithelium from any damage from the acid, and things like alcohol, aspirin, NSAIDs can affect this, even to some extent bile salts. Remember that the secretion of mucus and bicarbonate is going to be stimulated by prostaglandins. And once you have these prostaglandins being inhibited, for example, by a drug like aspirin or a drug like NSAIDs, which inhibit the cyclooxygenase pathway, this can actually lead to acids. So let me just show you a black screen so that I can explain this point very well. I know it may go over some of your heads. So you have phospholipids, right? Okay. And phospholipids are pretty much going to be broken down by phospholipase A2. So phospholipase A2. Okay, there are also some lipocortins that are going to be affecting this, but remember that it's going to be stimulated to break down phospholipids into a compound that's known as arachidonic acid. Arachidonic acid. So these reactions are very cardinal to inflammation. They're very cardinal to regulation of blood flow in certain areas. They're very cardinal to the lungs. Even in asthma, in the late phase of an asthmatic attack, we tend to see these reactions. So arachidonic acid can enter one of two pathways. So it can enter what is known as the cyclooxygenase pathway, which is catalyzed predominantly by cyclooxygenase enzyme. So cyclooxygenase 1, which is also referred to as a constitutional enzyme, meaning that it's constantly working. Then you have cyclooxygenase 2, which is what is going to be an inducible enzyme, which usually works in certain scenarios. For example, when you have inflammation going on. Then it can enter another pathway, which is known as the lipoxygenase pathway, which is going to be catalyzed predominantly by lipoxygenase enzyme. So I'll say lipoxygenase, LPO, lipoxygenase enzyme. So cyclooxygenase is going to give you prostaglandins. It's going to be giving you prostacyclins, that's PGI2. And it's also going to be giving you thromboxane A2, so TXA2. So it's going to be giving you prostaglandins, prostacyclins, and thromboxane A2. Then lipoxygenase pathway will pretty much give you your leukotrienes. Okay? So now, So you have different types of leukotrienes. So now with the prostaglandins that you're making, remember that these prostaglandins, especially prostaglandin E, if I'm not mistaken, these prostaglandins are the ones that are going to be stimulating the production of mucus in the stomach. They're going to be stimulating the production of bicarbonate to neutralize the acid. So when you use a drug such as an NSAID, okay, so you have certain NSAIDs which are known as the non-competitive inhibitors of COX-1 and COX-2, or the non-selective inhibitors, not really non-competitive, but non-selective inhibitors, meaning that they are going to be inhibiting both COX-1 and COX-2, and you won't be producing these prostaglandins, these prostacyclins, or thromboxane A2. Now, when you're not producing this, it means that the production of mucus will be decreased, the production of bicarbonate will be decreased, and this is going to be leading towards this person becoming pro-ulcerative. So this can lead to ulcers forming. On the other hand, you can also give corticosteroids. So the corticosteroids are pretty much going to be inhibiting the phospholipase A2 enzyme, and arachidonic acid won't be there. You won't have any of these reactions taking place. So corticosteroids, NSAIDs are pretty much, that's how they're going to be causing ulcers. So let me get back to this. So remember also that the duodenal mucosa has villi, and the rest of the small bowel is going to be containing these glands which are known as Brunner's glands, which secrete alkaline mucus. And this, along with the pancreatic secretions, the biliary secretions, is going to be helping in neutralizing the acid from the stomach when it reaches the duodenum. So now I want to go into details about how the acid is formed, but I don't want to read this slide to you. I first want to explain with the diagram, then we'll come back to the text. So there are two theories as to where the carbon dioxide actually comes from in the parietal cell. Because remember, this is the parietal cell. But let me give you some basic anatomy. So you have another parietal cell here, another one at the bottom here. So you have the lumen here, which is pretty much in the stomach, and you have a blood vessel here at the end. So these are just two different diagrams. Don't take them as two different diagrams. Here you have the lumen on the other side. Here you have the plasma or the blood vessels on the other side. So remember that in most cells, in the membrane which is facing the blood vessel is known as the basal membrane. This is known as the lateral membrane. Then the one that's facing the lumen is known as the apical membrane. So in most cells, at the basal membrane, you will always have a sodium-potassium ATPase pump. Remember that the sodium-potassium ATPase pump is going to be pretty much pumping out 3 sodium ions in exchange for 2 potassium ions. So you always have the sodium-potassium ATPase pump at the expense of 1 ATP molecule. So there's one school of thought that says that the carbon dioxide actually is as a result of metabolism of these parietal cells, and that's how it actually finds its way in the parietal cells. It's because of a byproduct of metabolic processes happening in the cell. Another school of thought is that the carbon dioxide actually diffuses from the bloodstream. So from the plasma, it's diffusing into the parietal cells. From the plasma, it's diffusing into the parietal cells. So whichever school of thought you're going with, just know that there is carbon dioxide present within these cells. So the carbon dioxide is going to react with water in the presence of carbonic anhydrase and give you carbonic acid. Then carbonic acid is going to dissociate into hydrogen ions and bicarbonate ions. So the bicarbonate ions can be exchanged for a chloride ion at the basolateral side, which is via a bicarbonate chloride exchanger. Remember, this chloride is entering into the blood, and these reactions are happening when someone is just from eating. So it means that the blood that's coming from the GIT is going to be alkalinic in nature. So this is what's going to be responsible for what we refer to as the alkaline tide. So you get the bicarbonate out, you get the chloride in. So what about the hydrogen ions? So the hydrogen ions on the apical lumen, you have an important channel. This channel is very important because when we give drugs, which are known as proton pump inhibitors, they inhibit this channel over there, which is known as the hydrogen-potassium exchanger. So hydrogen-potassium ATPase pump, so hydrogen-potassium exchanger. So it's going to be pumping out 1 hydrogen ion for 1 potassium ion at the expense of ATP. But remember, potassium will keep accumulating because it's coming in from the basolateral side or the basal side via the sodium-potassium ATPase pump. It's coming in via this exchanger. So these cells are actually quite rich in potassium, such that there is a channel on the apical lumen which allows potassium to enter back into the lumen. The chloride that has been entered from the basolateral side is eventually also has a chloride channel that's going to be pumped out. There are some people that actually assume that it uses the same channel, so that's why I added these two diagrams. They're pretty much talking of the same thing: the bicarbonate chloride exchange at the basolateral side, the chloride channels, and the potassium channel, and the potassium is going to be exchanged for the hydrogen ions. And then eventually you have the hydrogen ions in the lumen, you have the chloride in the lumen. In the presence of water, it's pretty much going to be forming the hydrochloric acid. So we can sometimes give a drug that's known as a proton pump inhibitor that will inhibit this this hydrogen potassium ATPase pump. So let's have a look at what the text is saying. So the apical membrane contains the hydrogen potassium ATPase pump as well as chloride channels, even potassium channels. Then the basolateral side is going to be consisting of sodium potassium ATPase, the chloride bicarbonate exchanger, and the parietal cells also contain an enzyme that's known as carbonic anhydrase. So carbon dioxide will react with water in the presence of carbonic anhydrase to form carbonic acid, which dissociates into hydrogen ions and bicarbonate ions. The hydrogen ions are going to be secreted along with chloride ions into the lumen, whilst the bicarbonate is going to be absorbed into the bloodstream. So at the apical membrane, the hydrogen ions are going to be exchanged for potassium ions. The potassium leaves via potassium channel found on the apical membrane, and at the basolateral side, the chloride is exchanged for bicarbonate. So this is responsible for the alkaline tide that we see from the gastric venous blood after a meal. So I really hope that makes sense. So remember that the acid is actually not essential per se for digestion, but it actually prevents some foodborne infections. It's also going to be under the control of both neural and hormonal control. So both can actually stimulate acid secretion. For example, if you're just thinking of delicious food, acid is going to be secreted from your stomach. Then it's going to be under the influence of certain hormones or certain compounds such as gastrin, which is produced from the G cells. It stimulates acid production. It's going to be stimulated by the histamine, which is produced from the enterochromaffin cells. It's also going to be stimulated by acetylcholine, which is produced from the vagus. So all these things can actually stimulate acid secretion. Then somatostatin will inhibit the production of histamine, gastrin, and therefore reduce the release of acid. And then also it's going to stimulate the production of bicarbonate and mucus. So remember that the stomach is going to be a reservoir for food. It also functions in emulsification of fat and mixing of gastric contents. It helps with secretion of intrinsic factor as well as absorption, but to a minimal extent. And remember that gastric emptying is going to be depending on many factors. So there are some osmoreceptors in the duodenum that actually control gastric emptying by local reflexes and release of gut hormones. So in particular, intraduodenal fat. If you have fat present in the duodenum, this will decrease gastric emptying. So if you eat a very fatty meal, you may not feel hungry for quite some time. So this is by negative feedback from the duodenal receptors. And remember that acid secretion is under three phases. Cephalic, so just the thought, the sight, the smell of food is going to be stimulating the vagus to produce acetylcholine, which will stimulate the parietal cells to produce the acid. Then you can have the gastric phase, where you have distension of the stomach by food. So this is going to be directly stimulating the secretory cells, and also it causes release of gastrin. Then you have the intestinal phase, where there's passage of food into the duodenum that releases certain gastric hormones that will eventually secrete acid in the stomach. So these are the three phases of acid secretion: the cephalic phase, the gastric phase, and the intestinal phase. So let's talk now about gastritis. So remember, there are things that are influencing. Histamine is going to be working via a G-stimulatory coupled mechanism via adenylyl cyclase to stimulate the protein kinase A's, and obviously this will phosphorylate the potassium hydrogen exchanger, and this will activate this channel. So histamine is going to be pretty much increasing acid production. The acetylcholine is going to be working by increasing calcium inside the cells and also stimulating the protein kinase enzymes to phosphorylate this channel and increasing acid secretion. The same thing is happening with gastrin. So histamine, acetylcholine, which is coming from the vagus, and gastrin, which is coming from the G cells, and histamine, which is coming from the enterochromaffin cells, are pretty much going to be increasing acid secretion. Prostaglandins, on the other side, act by a G inhibitory coupled receptor, which is going to be pretty much inhibiting adenylyl cyclase, thereby inhibiting protein kinase enzymes, thereby inhibiting this channel and decreasing the acid secretion. It's also going to be leading to increase in bicarbonate and mucus production. So I hope you understand that. So when you talk about gastritis, this is just pretty much inflammation of the gastric mucosa, although endoscopists actually usually use this term when they see redness sometimes. So the word gastritis is not synonymous with dyspepsia, what people call as gases. So that's a different thing. Or gastric erythema, which is seen on endoscopy. It's purely just inflammation of the gastric mucosa. So remember, in gastritis, there is disruption of the mucus layer, stimulation of acid secretion, and a decrease in production of bicarbonate, which is eventually going to lead to direct damage to the epithelium. So it can be classified as acute gastritis as well as chronic gastritis. So in acute gastritis, it's commonly caused by Helicobacter pylori. I'll talk about this in details when we look at peptic ulcer disease very shortly. It can be caused by other things like drugs, NSAIDs, and aspirin. I've talked about these. These are going to be working by inhibiting the cyclooxygenase enzymes. Alcohol in high doses, severe stress, because with stress you have increase in parasympathetic output that can actually lead to excessive acid production. Then other infections like viruses, CMV, herpes simplex, mycobacterium, syphilis. Then patients usually are going to be asymptomatic, but at times they may have sudden onset of epigastric pain, nausea and vomiting with or without diarrhea. They may have upper GI bleeding, so they may have dark tarry stool, which we call melena, or they may have hematemesis where they're vomiting blood. They may have features of indigestion, and they may have neutrophilic infiltration, edema, and hyperemia of the gastric mucosa. So if we don't treat gastritis, it may actually progress to chronic gastritis. So there is no specific treatment of acute gastritis that is indicated, but often if there is an offending agent, we want to remove the offending agent. Then what about chronic gastritis? So here there is a distinction, and histologically you're going to be seeing lymphocytes. You're going to be seeing plasma cells infiltrating into the gastric mucosa. So you may have superficial gastritis, which is then going to be followed by atrophic gastritis, where there is distortion and destruction of the gastric glands, and then eventually it progresses to gastric atrophy, where there's loss of the gastric glands, which may sometimes even undergo intestinal metaplasia, where there's replacement of the gastric mucosa with the intestinal type of mucosa. Then finally, if this isn't addressed, it progresses to gastric carcinoma. So you can think of it as three types. Type A, I like to remember A for autoimmune. Type B, so B for bacteria. Then type C, C for chemicals. So type A is also known as chronic fundal gastritis. So it's pretty much going to be affecting predominantly the fundus and the body, but it does not affect the antrum. So this is going to be associated with autoimmune conditions such as pernicious anemia. So remember, here you have autoantibodies against the parietal cells, and remember that the parietal cells are the ones that are going to be responsible for production of intrinsic factor, which is needed for the absorption of vitamin B12. So if you don't have the intrinsic factor, you don't have the B12, it means this patient is going to be having pernicious anemia or macrocytic anemia, a type of macrocytic anemia. Then you have type B, which is the bacterial gastritis or chronic enterogastritis. So this involves the antrum. It is the most common type, and it's going to be associated with H. pylori infection. So the inflammation may progress to involve the fundus and the body, and it can actually cause a pangastritis where the entire stomach is inflamed after about 15 to 20 years. So histologically, it's going to be improving when you eradicate the H. pylori. Then type C, we can think of this as the chemical. So this is due to repetitive injury with bile reflux, so duodenogastric reflux, or chronic ingestion of NSAIDs. So most people that have chronic gastritis actually may be asymptomatic. So generally treatment, if they have pernicious anemia, we want to give them B12. We can first actually get serum B12 assay to see how much B12 they have in their body, then give them B12. Then there is no need to treat the H. pylori unless if there is an ulcer or unless if there's a mucosal associated tumor, a lymphatic tumor or lymphoid tumor, or a lymphoid associated lymphoma. Then let's now go into details of looking at peptic ulcer disease. I'll talk about the management because the management largely is quite similar with gastritis and peptic ulcer disease. So remember that a peptic ulcer is pretty much a break in the superficial cells, the mucosa, penetrating down to the muscularis mucosa, which is found in the submucosa of either the stomach or the duodenum. If the ulcers are found in the stomach, you refer to that as gastric ulcers. If they're found in the duodenum, you refer to those as duodenal ulcers. So you have to be able to distinguish between an ulcer and an erosion. Remember, an erosion just affects the superficial mucosa. It just affects the mucosa. It doesn't extend into the submucosa. Remember that the layers of the GIT are going to be having the mucosa, the submucosa, which has a muscularis layer or a muscular layer, the muscularis layer or the muscle layer, which has 2 or 3 depending on where you are in the GIT, and the serosa. And when you talk about peptic ulcer disease, so there is discrete destruction of the cells, the superficial layers of the cells, by the acid and to some extent even by pepsin. So most duodenal ulcers are going to be found in the duodenal cap, and the surrounding mucosa usually appears inflamed, hemorrhagic, friable, so they may have a duodenitis. Then gastric ulcers are commonly seen in the lesser curvature near the incisura, but can be found in any part of the stomach. The duodenal ulcers are going to be commonly affecting approximately 10% of the adult population and are 2 to 3 times more common than gastric ulcers. Then the peptic ulcer disease occurs more commonly in males than in females, and it's much more common in individuals between 25 to 64 years. 90 to about virtually all types of duodenal ulcers are attributed to H. pylori, and 75 to 85% of gastric ulcers are attributed to H. pylori infection. So what are some of the protective factors and aggravating factors that can tip someone into having ulcers? So you may have protective factors. Of course, the surface is covered by mucosa. There is bicarbonate that is present. The mucosa itself rapidly regenerates. There is a normal mucosal blood flow in case of any acid that seeps in between the cells. It can be carried away by the bloodstream or neutralized by the bloodstream. There's also just this normal mucosal prostaglandin secretions, which are pretty much going to be stimulating inhibiting acid production, stimulating mucus synthesis, stimulating bicarbonate synthesis. Then the things that can cause ulcers include H. pylori. I'll talk about it in details. I've talked of NSAIDs, corticosteroids, and aspirin, smoking, alcohol, psychological stress, and even Zollinger-Ellison syndrome. So Zollinger-Ellison syndrome is where you have a tumor, more or less in the pancreas, that is going to be producing gastrin. So this gastrin-producing tumor will increase the acid production, and it can actually cause ulceration in individuals. So what is the causes of peptic ulcer disease? H. pylori is a very big thing. So remember, H. pylori is a slow-growing spiral gram-negative flagellate, which is urease-producing bacterium. So it's going to be acquired via the fecal-oral route or the oral-oral route, and it's going to be colonizing the mucosal layer in the gastric antrum, but it may also be found in the duodenum in areas of gastric metaplasia. So it's found in greatest amounts under the mucosal layer in the gastric pits, where it's going to be adhering specifically to the gastric epithelial cells. So it's going to be protected by the gastric acid, by this juxtamucosal mucus layer, which of course even traps some bicarbonate, so it hides. And the bicarbonate, which is secreted by the anthrocells, and it also produces ammonia by a certain enzyme which is known as urease. So what are some of the mechanisms as to which H. pylori can cause damage to the mucosa? So one thing is that it's going to be inducing the production of interleukin 8, which recruits neutrophils and causes an inflammatory reaction to happen in the stomach. Number 2, it produces urease. It consists of an enzyme that's known as urease, which is going to be cleaving urea to ammonia and carbon dioxide, and this actually creates a buffer against the HCl. The ammonia also stimulates the release of gastrin. It also stimulates the release of acid. Then there is enhancement of gastric acid secretion and impairment of duodenal bicarbonate production. It also adheres to the epithelial surfaces, and it's going to be secreting certain enzymes that, for example, phospholipase, adhesins, platelet activating factors, and protease enzymes like catalase and lipase, which are actually going to be directly damaging or digesting the layers of the mucosa. It can also produce a passive urea transporter that causes cell injury. It causes vacuolization. It may also produce cytotoxic associated proteins and vacuolating toxins that have been implicated in the development of ulcers. This is just some of the mechanisms as to how H. pylori causes mucosal damage. You may also have NSAIDs, aspirin, and corticosteroids, which pretty much inhibit the production of prostaglandins and thereby decreasing mucus production, decreasing bicarbonate, impairing the blood flow, as a consequence, leading to gastric ulcers as opposed to duodenal ulcers. You may also have alcohol, smoking. You may have uremia and radiation therapy. I want to take some time with severe burns, which I also refer to as Curling's ulcer. You can remember a curling iron to remind you that burns can cause Curling's ulcers. So remember that when someone is having burns, they may have a lot of third spacing. They may have a systemic inflammatory response. So often they may come in shock. They may be hypovolemic. They may be dehydrated. And remember, whenever you're dehydrated, the two organs that suffer tend to be the skin and the GIT. So blood is diverted away from the GIT and there's a decrease in supply of blood to the GIT. So this actually affects the amount of acid that can be neutralized, the one that seeps into the mucosa, and even the one that can be carried away by the blood that's flowing to the stomach. So again, if you don't have enough blood going to the stomach becomes ischemic. It can easily ulcerate. Then you have the Cushing's ulcer, which is associated with increased intracranial pressure. So it may be in the background of someone with head trauma. So remember, the increase in intracranial pressure increases the parasympathetic nervous system, increases stimulation of the vagus. This leads to increase in production of acid, and this is seen with head injury. You can also have this with severe psychological stress or even physiological stress. What are the clinical features? So they depend on the ulcer location and the patient age, but generally it's a chronic and a recurrent course. Pain is the most common symptom. Usually it's going to be burning and gnawing, or sometimes even felt as hunger in the epigastrum, and is relieved by food or antacids. Sometimes it may not be relieved by foods or antacids. So with the gastric ulcer, generally the symptoms often don't follow any consistent pattern, especially when the ulcer is going to be located in the pyloric channel, where the symptoms of obstruction may predominate. So they may have bloating, they may have nausea, they may have vomiting, which is due to the edema and the scarring. Then with the duodenal ulcers, generally the pain is going to be consistent and usually absent when the patient wakes up, but appears in the morning and is relieved by foods. Then it recurs again 2 to 3 hours after a meal. And the pain is actually quite severe with duodenal ulcers, such that they can actually wake up at night. Remember, anything that wakes you up from your sleep actually causes you significant pain. So remember that the relationship between pain and food is actually quite variable. In clinical practice, you may actually not even get this typical thing, and it's not really helpful in making a diagnosis. So remember, classically we say that the pain of duodenal ulcers classically occurs at night as well as during the day, and it's worsened when the patient is hungry. So it's not really a reliable sign, but you may use it as a learning or a stepping stone. Remember that with gastric ulcers, the more you eat, the more acid is being secreted in the stomach, the more painful it becomes. So gastric ulcers usually associated with pain upon eating, and with hunger, generally the patient is going to be having better relief. So it means that patients that have gastric ulcers tend to lose a lot of weight. Then on the other end, with duodenal ulcers actually are made better with food. So as long as you're hungry, the pain is going to be worse. And as you eat, you secrete these pancreatic juices that soothe the ulcer, and this bicarbonate and the mucus that soothe the ulcer and make it better when you eat. But when you're hungry, the pain is worse. So this is just a distinction that can help you distinguish whether this person has a gastric ulcer or a duodenal ulcer. Then they may have nausea, which is maybe accompanying the pain, the vomiting, which is infrequent, but it can actually relieve the pain. The anorexia and weight loss is particularly common with gastric ulcers, like I said. They may have persistent and severe pain, which usually suggests that there is complication or perforation into another organ. So remember that the duodenal ulcer pain becomes constant and is no longer going to be relieved by foods or antacids. It may sometimes radiate to the back or to the upper quadrant, and this may actually be a signal that there is perforation or involvement of the pancreas. And then with the duodenal ulcer pain that is accentuated rather than relieved by food and is accompanied by vomiting, this usually indicates that there may be some gastric outlet obstruction. Then you may also have abrupt, severe, and generalized abdominal pain, which is characteristic of free ulcer perforation into the peritoneal cavity. So there's a risk of this perforating and actually causing a peritonitis. So back pain usually suggests that there is penetrating posterior ulcer, and usually severe ulceration can occasionally be symptomless, as many of these patients with acute ulcers or acute bleeding or perforation have no preceding symptoms. Then when you do your physical examination, there may be some epigastric tenderness. You may get features of anemia, especially if they are bleeding. You may also get signs of peritonitis if there is a perforation, and you may sometimes have a positive succussion splash, which is detected in gastric outlet obstruction. So here's the distinction between the two. So you have the duodenal ulcers and the gastric ulcers. So duodenal ulcers are uncommon before 16 years. Gastric ulcers may develop in a child as young as 5 years, but the peak incidence is later than that of duodenal ulcers. Generally, duodenal ulcers, the pain is relieved by food or antacids, but this isn't really a reliable thing. Then gastric ulcers, the pain is aggravated by food. Then the pain of duodenal ulcer is characteristic, comes 2 to 3 hours after ingestion of food. So these are hunger pains. And then the pain comes 30 minutes into ingestion of food with gastric ulcers. Nausea and vomiting is not so common with duodenal ulcers. It's common with gastric ulcers. Weight loss is not so common with duodenal ulcers. It's common with gastric ulcers because the patients even tend to fear eating because they are going to be in a lot of pain. Perforation is much more common with duodenal ulcers than it is with gastric ulcers, and bleeding is much more common with gastric ulcers than it is with duodenal ulcers. I hope you have these distinctions in mind because this will help you clinically to judge whether the patient has a duodenal ulcer or a gastric ulcer. Then what investigations can we do? One thing that we can do is an endoscopy. So this is actually the most sensitive and specific method for the diagnosis of peptic ulcer disease. So this is, you can do an esophageal gastroduodenoscopy. So this is an imaging test where you visualize the esophagus, the stomach, and the duodenum in real time. So you have direct visualization, and you can sometimes even get a photograph. You may sometimes even get a biopsy and send it for histology, especially if you find anything else that is out of the normal or suspicious of malignancy. So this actually permits mucosal biopsy for detection of H. pylori infection, and it also provides a baseline reference for assessment of the ulcer healing. Then you may do H. pylori tests. So generally, you should stop the proton pump inhibitors 2 weeks before you do this test. There is something that's known as a stool antigen test, which is about 97.6% sensitive and 96% specific. Then you may sometimes do a carbon-13 urea breath test, which is 90% sensitive and 96% specific. So how do we do this? It's actually quite simple and quick. So you give them to ingest the carbon-13 urea. Then after that, you test their breath. Remember that urea is going to be broken down into carbon dioxide and ammonia by H. pylori. So if you actually get a certain amount of carbon dioxide that contains the carbon-13 and when in it, then obviously it's going to be positive for H. pylori. But this test actually, the sensitivity can be improved by ensuring that the patient has not taken any antibiotics in the past 4 weeks and they haven't taken any proton pump inhibitors in the past 2 weeks. Then sometimes you may do a barium studies, so barium meal or barium follow-through. The sensitivity of this is about 70 to 90%. We don't do this routinely. For our patients, we usually just push them towards an endoscopy. And remember, before they do an endoscopy, make sure that the HB is at least boosted to around 10 grams per deciliter if this person had features of anemia or had features of bleeding. Then, of course, a full blood count may show iron deficiency anemia. And another thing, before they actually go for endoscopy, you should stop the iron supplements because they tend to paint the gut and you may not see a very good picture. And the other thing is that before the patient actually goes for endoscopy, you should starve the patient the previous night. So how do we manage? So we remove any offending agents, we stop smoking, avoid coffee, avoid foods that can aggravate the symptoms. Then, of course, if they just have indigestion or dyspepsia, the so-called gases, you can give them magnesium trisilicate, which is MMT. Again, 1 tablet or 2 tablets that they can chew whenever they feel the discomfort, or aluminum hydroxide, 500 milligrams to a gram, which they can also chew. Then for acid reflux, you can just give them omeprazole, 20 milligrams, orally twice a day. Then if you're suspecting H. pylori, so there is no single agent which is effective in eradication of H. pylori. That's why we tend to combine them so that we get a better outcome. So we can use a regimen that consists of the following drugs: omeprazole, clarithromycin, metronidazole. That's one regimen. Omeprazole, amoxicillin, and metronidazole. That's a second regimen. Or you can use omeprazole, clarithromycin, and tinidazole. Or you can use omeprazole, amoxicillin, and tinidazole. I hope you keep that in mind. So omeprazole 20 milligrams twice a day or 40 milligrams once a day. Clarithromycin, we usually use 500 milligrams twice a day. Metronidazole will be at 400 milligrams 3 times a day. Amoxicillin, we give it at a gram 3 times a day. And they should be treated for 14 days. 14 days. Remember, they should be treated for 14 days. Then you may sometimes go for quadruple therapy, where you use bismuth subsilicate 2 tablets 4 times a day, omeprazole 20 milligrams twice a day, metronidazole 400 milligrams TDS, and tetracycline 500 milligrams QID, which is 4 times a day. Then you treat this for 14 days, and this is used for patients that have eradication failure. Then you may sometimes have some surgical treatment, especially if there's perforation, if there's obstruction that's not responding to medical therapy, uncontrolled or recurrent bleeding, suspected malignancy, symptoms refractory to medical management. Generally, you want to involve the surgeons. Complications of peptic ulcer disease include hemorrhage, anemia, penetration to other organs like the pancreas and the liver, perforation, gastric outlet obstruction, pyloric stenosis, and stomach cancer, which is why it's very important to treat peptic ulcer disease. Coming back to our warm-up question, a 54-year-old man complains of burning epigastric pain that usually improves after a meal and is occasionally relieved with antacids. On examination, he appears well, and besides some epigastric tenderness, on palpation, the rest of the examination is normal. Upper endoscopy confirms a duodenal ulcer. Which of the following statements concerning PUD is most commonly or most likely correct? Duodenal ulcer is seen more often in older patients than is gastric ulcer? No. Clinically, gastric ulcers are more common than duodenal ulcers? No. Duodenal ulcers can frequently be malignant. Okay. Infection can cause both types. So this is the best answer. Infection, H. pylori, can cause both type of ulcers. Then peptic gastric ulcers are usually quite proximal in the stomach. No. So we'll go for D as the answer. I really hope you enjoyed learning about peptic ulcer disease and gastritis. If you did, consider subscribing to the channel. See you in the next video. To Zambia and beyond. My name is Dr. Moses Kazevu. Until next time, bye-bye.